And okay, I'm so glad have the opportunity to have make the lecture to the experts from the United States and China. So I will begin my report. Hmm. Okay. Could you see the report?
Yes. Yes.
Okay, okay. I will start my report. This report is about the interpretation of the expert consensus on thermal ablation therapy for papillary thyroid cancer. This is the newest edition, 2024. Oh, okay. I will going on my lecture on the following aspects.
哎，
Okay, first,
王主任你好，不好意思打扰一下，您能试一下就是那个退出然后共享整个屏幕吗？我们现在看到的是静止
我现在就是共享的整个屏幕啊，
啊，现在开始动了，
现在是吗？
现在看得到这个 introduction。
王老师你好，我想问一下，您现在用的是演讲者视图吗？您在那个切换那里，
我现在用的是共享屏幕，
呃，
现在能
我
看到吗？
们现在，我们看不到您翻页，我们只能看到您在一个主页面上。
哦，看不到
对，
翻页啊。
您，对
嗯，
对
那
对，
等一下，
您
我
点击那个切换那里，
你看一下现在能不能看到呢？
您
我翻页
翻
了，
页了吗？没有，
我翻页了。
没有看到，没有
那这
看到，
样
没有看到。
那我重新共享一下呢？等一下哈，
您可以。
我再重新共享一下，我再看一下。不应该呀，我看看。
王
嗯，
老师可能是那个演讲者视图的原因，您共享之后点击给我看一下
我应该选 WPS Office 还是？
您选桌面比较好，
但是
对
我这儿哦，选桌面哈，马上哈，现在
对，
能
您
看到吗？
选桌面可以，然后您共享，我们这边看一下，
现在怎么样？能看到翻页吗
稍等，您翻页一下，可以，OK
现在可以了，
OK，
现在可以了。
？OK，
好的好的，
现在
谢谢。
可以哈。OK OK，好，那我接着来哦。现在可以看到哈。Okay, the first and foremost is the introduction. Okay, uh, a moment, please. Okay, the backbone. Sorry, the 等一下我看 moment, please. The background and the incidence rate of the PTC. As we know, the PTC is the most common malignant tumor of the thyroid gland, and this carcinoma is one of the most common malignant tumors in the endocrine system, accounting for the vast majority of all thyroid malignancies. And the incidence rate is going on. Sorry. The incidence rate is going on in recent years because of maybe the genetic or the environmental factors, such as radiation exposure and iodine intake are considered to be associated with the occurrence of PTC. The application of thermal ablation therapy in PTC, we can see the basic principles of the thermal ablation therapy. The thermal ablation therapy involves generating high temperatures to ablate tumor tissue, mainly including the microwave ablation, radio frequency ablation, or the laser ablation. The advantages of the thermal ablation therapy, as we know, it is minimal invasive, effective, and safe, as well as fewer post-operative complications and faster recovery. With the development of the thermal ablation therapy, it has gradually become one of the important options for treating PTC, especially suitable for the lowest risk papillary microcarcinoma of the thyroid. So as we know, the lowest PTMC is the most suitable. And the purpose and the significance of the consensus is to standardize and promote the clinical application of the thermal ablation therapy, so it can improve the safety and effectiveness of the treatment. Okay, the second one is the overview of the thermal ablation technology. First, the definition. As we know, under the ultrasound guidance, the ablation needle is inserted into the tumor tissue, and it can introduce a high temperature to destroy tumor tissue. And meanwhile, it can promote the immune response of the body, and also can induce the coagulative necrosis. So now normally we use at the redundant we use the radio frequency ablation, microwave ablation, laser ablation. In recent years, we also use high-intensive focused ultrasound ablation in the clinical trials. Right now, in our center, we are going on this method. The advantage of the thermal ablation technology is minimum trauma, fast recovery, and fewer complications. Okay, the most important is the advantages of the TA compared with the surgical resection. Multiple studies have shown that the efficacy of the thermal ablation in treating PTC is comparable to the surgical resection, even better than surgical resection in some aspects. It has a higher security compared with the surgical resection. The thermal ablation therapy has higher safety, however, lower incidence of the majority pro-operative complications, and does not require lifelong hormone replacement therapy. I think this point is very important. Thermal ablation therapy is also a minimum invasive surgery that causes minimal trauma to the patients, resulting in faster post-operative recovery and higher quality of life. Okay, the third point aspect is the expert consensus interpretation. Okay, so first of all, we need the neck ultrasound, assess the structure of the thyroid gland and surrounding tissues, so as to determine the location, size, and quantity of lesions, and whether there is lymph node enlargement. And then we will do the puncture biopsy. By performing pathological examinations through tissue biopsy, the tumor type and staging can be determined, providing a basic basis for treatment. The puncture biopsy is very important, whether for the thermal ablation or the surgery. And then the thyroid function, we need to detect the patient's thyroid function indicators such as T3, T4, TSH, and so on, to understand their thyroid function status and prepare for the treatment. And then the indication and contraindication is very, very important before treatment. Indication, thermal ablation therapy is suitable for the low-risk thyroid papillary carcinoma and other tumors. Its effectiveness and safety have been confirmed by multiple studies. In this consensus, it describes the recommend the thermal ablation as one of the first-line treatment methods for T1A N0M0 PTC. This point is highly recommended. It means between 0 to 10 centimeters tumor, it can be recommended for the thermal ablation as the first line treatment. But for the T1B N0M0 PTC, it is recommended that get the thermal ablation as one of the optional treatment methods. This point is also highly recommended. Okay, that one is the contraindication. Patients with severe cardiopulmonary dysfunction and recurrent longitudinal nerve injury that has not yet recovered from the initial surgery cannot undergo thermal ablation treatment. Okay, this is very important, the contraindication. Okay, the following is also the contraindication and precautions. Patients with mental abnormalities or conscience disorders that have not been effectively corrected due to patients unable to cooperate with treatment, they may be at increased risk of complications. Therefore, special attention is needed. Patients with neck extension disorders caused by various reasons. Due to the patient's inability to cooperate with treatment, there may be an increased risk of complications. Therefore, special attention is needed. The third one is the patient with severe coagulation dysfunction or oral anticoagulants that have not reached the discontinuation time because due to the abnormal coagulation function in patients, there may be an increased risk of complications such as bleeding. Therefore, special attention is needed. And due to the poor cardiovascular function in patients, there may be an increased risk of complications. There also special attention is needed. So the first part is preoperative preparation and operating procedures. Okay, introduce the advantage of PTC thermal ablation therapy is very important before the treatment. We should tell the patients talking about the advantage of the PTC thermal ablation. During preoperative conversations, doctors should introduce the advantage of PTC thermal ablation therapy to patients, including minimally invasive, effective, and safe treatment. Also, doctors should answer patients' questions and increase their confidence in treatment. This part is very important and also highly recommended in the consensus. And during the preoperative conversation, the doctor should inform the patient of the general process of the surgery and the expected therapeutic effect, including the steps, time, expected therapeutic effect of the surgery. And the doctors should also answer patients' questions and reduce their anxiety. And during the preoperative conversations, doctors should inform patients of possible complications and preventive measures, including bleeding, recurrent laryngeal nerve injury, and superior laryngeal nerve injury. And doctors should answer patients' questions and reduce their fear. And preoperative assessment of the patient condition. Before surgery, before the treatment, doctors should conduct a comprehensive assessment of the patient's condition, including ultrasound evaluation, physical examination, and so on. Also have a detailed understanding of the patient's medical history and medication use. So before the surgery, doctors should be equipped with necessary emergency drugs and equipment, such as some drugs for emergency. Also should be proficient in first aid skills so that they can respond promptly in case of unexpected situations during surgery. And also doctors should keep in touch with their superiors so that they can promptly seek help in case of unexpected situations during the operation. At the same time, doctors should also maintain contact with colleagues so that they can help each other when needed. Okay, the following is the operating procedure. Arrangement of patient position. Patients generally adopt the supine position with the pillow removed and the neck extended to fully exposed to the neck. For patients with obesity, cervical spondylosis, or hunchback, they can be placed in a more comfortable position by using low pillows, back cushions, and other methods to facilitate operation. The general principle is based on patient comfort and physician convenience. And the following one is the ultrasonic evaluation. Before and during surgery, doctors should perform ultrasound evaluation to determine the location, size, and other information of the lesion. Meanwhile, doctors should also develop personalized treatment plans based on ultrasound results. Prior to surgery, doctors should disinfect and drape the patient's neck to prevent complications such as infection. So also pay attention to the principle of aseptic operation to avoid unnecessary infection risk to patients. And the selection of anesthesia methods. The anesthesia method can choose local anesthesia or cervical plexus anesthesia and so on. And doctors should choose the most suitable method based on the specific condition of the patient. Okay, the consensus highly recommend the local anesthetics should not be injected in the recurrent laryngeal nerve pathway area. This is very important. The next one is also very important. It is about the liquid isolation technology. During the surgery, doctors should use liquid isolation technology to separate the lesion from surrounding tissues and organs to prevent complications such as thermal injury. Doctors should adjust parameters such as injection location and the dosage of isolation fluid based on the ultrasound results. Continuous injection or single injection of isolation solution. Maintain isolation distance above half centimeter. This one is very important. This is also highly recommended in the consensus. And the next one is also very, very important. During the operating time, contrast enhanced ultrasound is recommended to evaluate ablation outcomes. This is also highly recommended in the consensus. You can see before microwave ablation and after microwave ablation, there is no continuous enhanced area after the microwave ablation. The contrast enhanced ultrasound is normally used in our center. I think this is very important evolution time, the evolution method. The matters need attention. Unilateral multifocal lesions suggest ablating the lesion near the posterior membrane first. Okay, this is the first one. The second one is bilateral multifocal lesions suggest ablating the safe side first. And the last one is also important, is if the patient has sound changes, contralateral lesions need to be ablated after nerve function is restored. The second one and the third one is highly recommended in the consensus. Okay, the last part is the post-operative management and management of complications. Okay, the PTC patients should receive regular follow-up examinations after thermal ablation. This is highly recommended in consensus. So normally we going on the ultrasound imaging examination. This one is performed at 1 month, 3 months, 6 months, and 1 year post-operative to evaluate the extent of ablation and treatment efficacy. And the thyroid function examination is also should be conducted at 1 month, 3 months, 6 months, and 1 year after surgery to assess thyroid function status. And the risk of tumor recurrence. So the clinical symptom observation observes the changes in clinical symptoms of patients after surgery, such as sound, breathing, swallowing, and properly detect and treat possible complications. And during the post-operative follow-up, neck lymph node ultrasound should be performed simultaneously. If lymph node metastasis is suspected, FNA is recommended for diagnosis. Okay, this one is highly recommended in the consensus. And the TSH separation separation therapy is no consensus. because the TSH suppression therapy after the surgery. Normally, doctors use this method for the uh, for the for the surgery and for the thyroid resection patients. But for the for the TA patients, if the risk of tumor recurrence is relatively high, the TSH suppression can be reduced to half to two in the early post-operative period. So this is not in the consensus. Regular schedule, post-operative patients should follow a regular schedule, ensure sufficient sleep time, avoid excessive fatigue in order to promote physical recovery and maintain a healthy state. And the post-operative patients should maintain emotional stability, avoid emotional excitement, tension, anxiety, and so on, so as not to affect the treatment effect and the post-operative recovery. And the post-operative patients should take some stress relief measures, such as listening to the music, doing yoga, and so on, to relieve stress and maintain physical and mental health. Okay, if the rapid bleeding occurs during the operation, it is recommended to perform intraoperative ablation to stop bleeding. This one is highly recommended in the consensus. Recommend using the ultrasound to observe vocal cord movement during surgery to assess the recurrent laryngeal nerve function. This one is also highly recommended. The swallowing training is recommended after injury to the superior laryngeal nerve. Okay, this is highly recommended. The swallowing training may make sense for this for the injury of the superior laryngeal nerve. Okay, maybe that's all. Thank you very much. And okay, welcome to the
Thanks.
following discussion. Okay.
Okay, thanks to Dr. Wang. And dear America Express, please raise your question and share your valuable opinions. Thank you. Okay, any question?
Hi, I have a question. Can you hear me? Hello?
Yes.
Difference between mobile aberration and fixed aberration. Can you hear me? The
Yeah.
difference between mobile aberration and fixed aberration.
Oh, you mean between the difference between the microwave ablation and the frequency ablation?
mobile aberration and 就是固定的和移动的消融。
Oh, okay. For the I think for the small leisure, I think the
How small? What size?
normally below the half centimeter.
Okay.
Half centimeter.
Okay.
The 0.5 centimeter, the micro carcinoma. Normally we the microcarcinoma is below 1 centimeter, but I think you had better do the below half centimeter. We can use stable ablation. But not next to the nerve or the nearby the nerve. Okay.
Thank you.
Okay, thank you.
Hi, Dr. Wang. I have two questions. Thank you. First of all, thank you for the wonderful talk. Question one is that you mentioned that the PTC between 0 to 10 centimeters, the microablation treatment is the first line. How long will you need it to do for this 10 centimeters? Do you need it to do twice, or it's in one procedure that you will complete the treatment?
Normally, for the microcarcinoma, we do normally we do once. No need twice. Or
Even 10 centimeter in size?
no.
Oh, the micro one. Oh, sorry. Yeah, you mentioned under one.
Yeah. The
centimeter.
microcarcinoma.
Yeah.
But
So,
normally we do we did the thermal ablation. Right now, we recommend the microcarcinoma for the thermal ablation. I think is the best suitable, but more than 1 centimeter to 2 centimeter, between the 1 to 2 centimeter, I think we can have choice, but I'm not sure if once is okay. Yeah.
okay. What about the 10 centimeters?
10 centimeter, we don't do it.
Okay, got you. Thank you. And the second question is that for the microablation technology to be used in regular, like the benign nodule versus the PTC, what's the difference, or the procedure is more or less the same?
You mean the you mean the procedures of the PTC
Yeah, so using
for
the
the
same.
micro for the for the microcarcinoma or
Right.
for the PTC?
For the microcarcinoma versus a benign nodule.
Versus the benign
So
benign.
so the procedure.
Oh, okay, I mean you mean the
Yeah.
malignant versus benign. Okay.
Right, exactly.
Okay. For the malignant tumor, I think we also normally for the benign tumor, normally we do we are doing with the more than 2 centimeter, between the 2 to 4 centimeter, we do it more. But for the malignant tumor, we normally do it below 1 centimeter. So the ablation time is different. I think for the benign tumor, we don't need to. It is not necessary to do the ablation completely. But for the malignant tumor, we should ablate the tumor laser completely. You know what I mean? Yeah.
Yeah.
Yes. I think the ablation time is very important.
Yeah. Great. Thank you very much.
Okay, thank you.
Hi,
Okay, go on.
Wong. One question about that. Comparing the benign and the malignant, is there any difference with the follow-up post-procedure? After the procedure is performed, is there any additional follow-up required for the PTC as opposed to just the microwave for the benign tumor?
Yes. I think for the we mainly for the PTC and for the benign tumor, there is a difference. I think before the surgery, before the treatment, the ultrasound evaluation is very important, especially for the lymph node ultrasound. Because normally some very small lymph node metastasis cannot be evaluated, cannot be seen by the ultrasound before the surgery. So when we're doing the surgery, after the surgery, the lymph node, very some small, very small, small size of lymph node metastasis can be found. But if we do the thermal ablation, we cannot make sure the lymph node metastasis is. So normally we don't do the lymph node ablation. So for the PTC or for the micro carcinoma of thyroid, we have to do the ultrasound evolution before surgery. This is one is very important, but and the location of the lesion is also very important. If the location, the tumor is near to and the close to the memory, normal we don't do it. The tumor lesion inside the thyroid gland, we can do the thermal ablation treatment. And the other one, the other point is, I think the age of the patient is also very important. I think 55. This is the I think before I think more than 55 age of 55 patient, we should do it carefully. Okay.
Thank you very much.
Okay, thank you.
Any question? We can welcome Dr. Yonghao Luo from Nanning. Okay.
Okay.
Okay. Welcome, Dr. Luo. He will present the complications and the management of microwave ablation of thyroid nodule. Welcome, Dr. Wang. Let's begin.
Can I begin?
Okay.
Thank you. Can you see my PPT?
Yes.
Yes, thank you, Dr. Lee. And every experts and colleagues, good morning and good evening. I am Dr. Yong Biao Luo from the Department of Hand and Neck Surgery, Cancer Hospital affiliate to Guangxi Medical University. Today, I am honored to share with you the complications and treatment. And management of microwave ablation of thyroid nodules. We all know that the incidence of benign nodules is increasing, and it is also a common disease. Among them, benign lesions amount for the majority. So how can we provide precious treatment for this group of patients? As to minimize the impact on their physiological, psychological, and social function, and enable them to better return to the society. I would like to say that ablation is an ideal choice. At present, many countries have published relevant guidelines and expert consensus, including China, Korean, European, and American. The latest and relatively new expert consensus is the International Multidisciplinary Expert Consensus published in 2021. This expert consensus was published by the United States, Britain, Europe, Italy, and other countries. And at present, there is no uniform standard for the size of benign thyroid nodules that can be firmly ablated. And we can see this consensus. They suggest a minimal diameter of 20 to 30 millimeter with continued groove on US. And at present, the consensus recommend 1 and 2 recommend US guide ablation procedures may be used as a first-line alternative to surgery. We can see that traditional surgery and microwave ablation there is different, and including traumatic surgical incision, thyroid function, and success rate. Microwave ablation is a very minimally invasive treatment and a therapeutic operation. For benign nodules, ablation therapy has the advantages of small damage, quick recovery, good rapidity, retaining the function of the and not affecting the appearance. But it still belongs to a category of surgery and will inevitably have an impact on patients. And we can see this image guide thyroid ablation proposal for standardization of terminology and reporting criteria, and it's free levels. We can see that the minimal size is side effects and minor complication and major complication. Side effects including pain, edema, vasovagal response, and cough and fear, and minor complication including hematoma, conservation management of nodule rupture, and so on. Major complication including sound alternation, permanent sound change, and nodular rupture requires invasive treatment. And the first one is side effects. The microwave ablation is a surgery, so the pain is I'm sorry. Pain is very common. And the pain is light to moderate, and it happened to neck of ablative area. Evidence at the capsule. It can radiate to the jaw, teeth, ear, shoulder, and so on. I think its management is we do not require treatment. This type of pain is mostly self-limiting and does not require treatment. If the patient is in pain, they can take some painkillers orally or add some anesthetics during surgery, as well as reduce the ablation power. When the patient's pain is more obvious, they can pause the rest and ablation temporarily. Edema is due to some reactions caused by our puncture into the thyroid gland, mainly manifest as a sense of swelling in the neck, and some patients will have some sense of pressure. Just like the ultrasound image on our picture, which can show this kind of hyper-echo stripes. And then our general treatment is that does not need to be treated, and most of it will subside spontaneous. So if the swelling is obvious, you can use some glucocorticoids and the trace will soon fade. There is also a vascular vagus reflex, which is mainly manifested in sweating, difficult breathing, bradycardia, hypertension, and so on. At this time, we need to stop ablation, give the patient oxygen therapy, and let the patient rest fully. After a few minutes, it can generally be relieved. One prevention measure such as intervention glucose infusion is to strengthen pain management. And one of its main principles is the stimulation of the vagus reflex here. And you can see the vagus nerves in here. The other side effect is cough. The incidence is very low. The patients themselves cough as well will make the cough, and some people had the airway sensitivity. So for large thyroid nodules near the trachea, we recommend some infiltration anesthesia and liquid quality on the surface of the trachea. Just like this ultrasound. So in the trachea surface, we fill in the infiltration anesthesia in the airway. When thyroid nodules are ablated, the ablation needle should be kept away from the trachea, and the power of the ablation should be reduced in a short and fast way. Minor complication is high blood pressure, and the patient had no obvious symptoms, and we had patients the blood pressures and maximum of 210 and 112 millimeter mercury. And now the patient is so nervous and has stress, including pain stimulation, and we can relieving emotions, pushing this dissolution, and taking oral blood pressure medication, and if necessary, we should sedation the ablation. Another minor complication is hematoma. The location is almost in the parathyroid gland, subcapsular, and now if it happened, we can most do not require treatment. We can press the puncture site ablation therapy and if necessary, the ablation therapy the vessels. We can see that the surface of thyroid gland has very rich blood vessels. So sometimes we may encounter a hemorrhage in the thyroid gland. this is our patients and nodular rupture. This rupture, they conservative treatment. So it's we can see this, their skin is red and infection. This situation is almost after operation 2 to 5 weeks, and we can see this patient's crystallis thyroid nodules, and it's benign nodule. And this is ablation on the CT field a month later. We can see that there is a rupture on the surface to the outside of the skin. In here, in here, and some the nodule rupture. This is the case of ultrasound imaging, and you can see that the whole nodule ruptures and protrudes outside. This is her skin infection. For this patient, we performed an anti-inflammatory dressing treat, and the patient recovered after a month. And ultrasound images showed that the rupture of the nodule had absorbed most of it, is smaller. This is a young female patient who is 18 years old. We can see it when we look at this CT, the thyroid gland is almost all nodules and very big. 1 month after we performed ultrasound guided microwave ablation of thyroid nodules, the patient developed redness and swelling in the neck. And we can see the CT here. This is the CT can see that we can see some lumps in his neck that had beneath the skin. We gave her a fibrotic bronchoscope, but the fibrotic bronchoscope did not find any damage to the organs. So we suggest that the patient undergo anti-inflammatory and dressing change. And after about a month, a sinus tract of approximately 1 centimeter will will form. Then continue to change the dressing treatment and use spur cream to smear. About half a month later, basically healed. We can see the formation of the scar in this video. Although it is relatively small, but when he swallows, it will lead to the linkage of the neck. Here has a adhesion. Just after we thought it had healed, not about half a month later, some secretion appeared in the scar of the patient's skin, and after we punctured it, there was some necrotic granulation tissue inside. And here we can see this tissue. We send the necrotic granulation tissue to pathology, and the pathological diagnosis was a granulation tissue of some neutrophil. This is a manifestation of the ultrasound image. We can see that there are some bad foods. There are some bad tissues under the skin breaking through to the outside. And here to the skin. About 4 months later, the patient's neck had healed and the brain thyroid gland was basically absorbed. Here the thyroid nodules almost absorbed. And here is the normal thyroid gland. And we can see that the scar has healed much better than before, and the adhesion has been significantly reduced. And this is a PTC patient near the trachea. Because the patient himself cannot tolerate surgery, we gave him a microwave ablation. A week after that, the patient had swelling and pain in his neck and gave him a CT examination, which showed that the patient's trachea was abnormal and particularly damaged. Here, and we can see the trachea is broken. When the patient has a trachea injury, we can see that there is some gas overflow under the ultrasound image, so that this time we need highly anti-infection. We need highly anti-infection treatment. If necessary, surgical treatment, and we still need to recommend adequate liquid quality during thermal ablation and move quickly with low power. And the patient basically healed after about a week of anti-inflammatory treatment, but we can still see that there is adhesion and damage between the patient's thyroid gland and muscle. And then the patient was re-examined about half a year later, and it was basically absorbed. This is a patient with a serious skin injury in another hospital. We can see that the patient's skin is all burned and there is red swelling and damage to the trachea here. For the patients like this, we still recommend an early surgical treatment, especially in the burn and plastic surgery department, as well as the world's stoma clinic. This is a relatively large thyroid nodule. We can see that the patient's artery is pressed to the back of the thyroid gland. This patient has a sudden vomiting. So vomiting occurs occasionally in thyroid formal ablation. Some patients also occurs after surgery. Once vomiting occurs, we recommend that you need to stop ablation and turn the patient's hand to one side. If necessary, painkillers can be used for treatment. And let's look at a few major complications. One of the more common serious complications is voice change, including hoarseness or permanent dysphonia. Voice changes usually occurred during or immediately after surgery, usually caused by injury to the recurrent laryngal nerve and vagus nerve or compression of a hematoma, which can be recovered in 1 to 3 months. In this ultrasound image, we can see that one of the vocal cords on the right side of the patient is movable, but the left vocal cord is fixed. And this nodular rupture need to invasive therapy. We can see an ultrasound image of this patient. This is the CT scan. The CT on the left here is the pre-operated image, and here is the rupture of the nodule. We can see that the neck is enlarged and the tumor ruptures. Here is very, very large. The patient had a rupture of the nodule about 2 weeks after the operation. So after the rupture, we advise the patient to undergo a dressing change and anti-inflammatory treatment. After about a week of anti-inflammatory treatment, the patient's symptoms improved significantly. But in the end, the patient still chose surgical treatment in other hospitals, and we also feel that this is pity. We have also checked the relevant literature reports. The literature reports generally do not recommend that surgical treatment, and it can be healed through conservative treatment, including dressing change and so on. The healing cycle is probably less than half a year. The occurrence of ulnar syndrome is mainly due to the shallow position of the cervical cervical stellate ganglion and the deep position of the thyroid nodule in some patients. So at this time, the microwave ablation of the thyroid nodule and the thermal ablation needle are easy to cause thermal injury to the stellate ganglion, which leads to an ulnar syndrome. At this time, the principle of treatment is the same as that of recurrent laryngeal nerve injury. We mainly focus on prevention. We must see clear where the tip of the ablation needle is. Hyperthyroidism generally occurs in multiple nodules. Excessive ablation, then this type patients will show hyperthyroidism. If this happened, we should recommend that the patients undergo a thyroxine replacement therapy and regularly review their thyroid function. At present, we have not had an implantation of tumor with we searched the literature and found that there were two cases. These two patients had a FNA puncture before ablation, suggesting a benign thyroid nodule, but recurrence after ablation and then the puncture, suggesting a malignant thyroid cancer. So before thermal ablation of thyroid nodules, we recommend a diagnosis with FNA, and if necessary, two punctures can be performed. After surgery, a regular follow-up should be conducted. If we want to improve the safety of thermal ablation of thyroid nodules, we need to carry out a whole process and specialized management. including during and after the operation, so as to ensure the effectiveness and safety of our ablation. Here is our hospital and our team. Thank you.
Thank you. Thank to Dr. Law and America experts. Please raise your question and share your valuable opinions on Dr. Law's presentation. Thanks. Any question?
Thank you, Dr. Law. I have a question. So I noticed that you're talking about all the complications during the procedure. So what the measures that can minimize the risk of the complication, such as a hematoma or the nodule rupture during the microwave ablation procedure? Hello, can you hear me?
My
Dr.
signature.
Law?
Yeah. Sorry. Can you repeat?
Yeah, what's the measures in the place to minimize the risk of the complications, such as the hematoma or the nodule rupture during the microwave ablation procedure?
Yeah. We can take we search the literature and think in and we recommend that the ablation is not too much time, and don't put it at the same time. Repeat it, and we think the nodule rupture it is the one of the most important reason to the rupture.
Thank you so much. So control time is very important, right?
Any question, please?
The rates of complication that you see, are they about the same for microwave ablation and radio frequency ablation and laser treatment?
I'm sorry, I just do the microwave ablation. I don't do that frequency ablation and laser treatment. I think this question should be asked the Dr. Lee or other experts.
I think should be same because this method use just the heat, use the heat to ablate. So I think the complication should be same. You must control the temperature and the time. It's very important. Yeah.
Thank you, Dr. Lee. So I think following Claire's question, she might be wondering about the rate of complication. So So for example, the frequency of these complications happened between the different techniques. I think that might be what,
Okay.
yeah.
Okay. Okay.
就是对于微波射频，然后可能激光这几种技术，就是发生这些竞技症的几率有没有明显的区别？大概这个意思。对
因为主要都是热疗嘛，都是一个加热的这个。
啊，OK，明白。
对，Okay, any question?
Yeah, so yeah, go ahead.
Oh, okay.
Yeah, go ahead, Lynn. Yeah.
Okay. Hi, Dr. Ruo. You mentioned that for handling the side effect such as cough, one recommendation that you mentioned is reduce ablation power. Could you go into a little detail on how to do that? Usually also can you comment that when you start the ablation, the wattage you use is 30 watts, right? And then are you when that side effects happened, do you reduce it to what wattage, or are you talking about more like reduced temperatures? Thank you.
Thank you. I think we just reduce the ablation power, and normal I use 30 volts. Some nodules I use 45. When when the thyroid nodule is location on the danger, it's very dangerous. For example, it's close to the airway, recurrent larynging nerve, and so on, and we can reduce this power.
Okay, and then to like maybe to 25 wattages, or how do you control the power when you mention that?
Yes, I will change the power to 25. Sometimes I can reduce it to 20 volts. And we can move the ablation needle quickly when we close to the danger location.
I see. Thank you very much.
Question more? More question? Okay, it's 11 p.m. in China, okay? And I think it's time to summarize of this meeting. Ms. Huang, can we summarize?
Yep, Dr. Lee. Yeah,
Okay,
definitely. Go ahead.
Okay, Dr. Wang and Dr. Law shared with us about their impressive insights on the stem ablation for thyroid disease. And our America experts raise questions and engage in discussion freely and offer valuable opinions and suggestions for the clinical practice of the thyroid microwave ablation technology. And thank you. Bye-bye. One.
Thank you. Thank you, everybody.
Bye-bye.
Thank you very much.
Bye.
Thank you very much.
Thank you.